everyone. We're so thrilled to have you join us for our next panel discussion at the Becker's and Lintas Hospital Operations Virtual Summit. We hope you've enjoyed the event so far. I'm Mackenzie Bean, Managing Editor at Becker's, and I'll be your moderator for today's panel discussion. I'm joined by 4 great panelists to discuss the tools and strategies in capacity management that clinical leaders need to support staff during and after the pandemic. Before I have the panelists introduce themselves, I just want to walk through a few quick housekeeping notes for our audience. All of our sessions are being recorded and they'll be available for on-demand viewing following today's events. If you have any audio or video issues during the session, please try refreshing your browser as that might help. You can also submit any technical questions into the Q&A box that you see on your screen. If you have any questions for our presenters, please submit them using that same Q&A box and we'll be sure to follow up with you directly after today's event. And finally, don't forget to check out all of our related content and be sure to fill out our session survey. So with that, I'd love to kick things off by having our presenters introduce themselves. Dr. Grimley, why don't we start with you?
Good afternoon, everyone. My name is Karen Grimley. I'm the Chief Nursing Executive at UCLA Health, and I am also the Assistant Dean at the School of Nursing at UCLA. I have been in healthcare for a really long time, and I have been the chief nurse here for just about 6 years now. So really looking forward to talking to you about the topics today.
Excited to have you here. Thank you. Dr. Swick, let's go to you next.
Hi, hello everyone. My name is Maureen Swick. I am the Chief Enterprise Nurse Leader Executive for Atrium Health. We cover 3 regions, 42 hospitals, about 1,500 locations, and serve about 7 million lives in our Southeast region. And I have also been in nursing for quite some time, and I'm really happy to be here and share some of our experiences post-pandemic and pandemic.
Happy to have you. And Tracy?
Thanks, Mackenzie. I'm Tracy Moffatt. I'm the System Chief Nursing Officer and Vice President of Quality and Safety for the Ochsner Health System down in New Orleans, Louisiana. Like my colleagues, I have been doing this for a long time, 30 plus years. And we're happy to talk to you all today about capacity management and the like.
Wonderful. Thanks, Tracy. And then Ashley, why don't you round us out?
Sure, thanks. Afternoon, everyone. My name is Ashley Walsh. I'm the Vice President of Client Services here at Lintas. At Lintas, we're fortunate to work with over 100 healthcare systems across the country. I've spent almost 2 decades in healthcare administration or leadership in some capacity, and I'm happy to be here today and share just some of our lessons learned and best practices in working with many organizations. Specifically today, I'll talk a little bit about on the capacity management side, as well as the perioperative services.
Wonderful. Well, thank you all again so much for being here. Really looking forward to the conversation. So let's just dive on in. I'm curious, what shifts to capacity management did your organizations make during the pandemic? And what have you really learned from this experience? Tracy, maybe we can start with you.
Sure. I think like a lot of hospitals around the country, we made early and significant shifts out of kind of what I would consider to be surgical services, procedural services, those kinds of things, and shifted, frankly, our staff from those areas into more of our inpatient settings. So that was one major shift that we made. I would say, Mackenzie, probably the other seismic shift, for lack of a better term, that we made, we had probably budgeted to do 3,000 virtual visits through our clinics in 2020, and we ended up doing 300,000 virtual visits. So another major shift that we made, kind of thinking outside the hospital, is how do we provide and care for treatment in the home for people through virtual access? And that was one of the major shifts that we made. So on the inpatient side, redeploying clinic nurses, redeploying procedural nurses into the inpatient setting, and then on the outpatient side, a lot more virtual work.
Please go ahead, Maureen.
Yes, I was going to say, I think in addition to what Tracy said about the procedural areas closing down and moving staff around, we also had a very large virtual platform, and we actually stood up our virtual hospital and observation, where we were able to see, I think, 90,000 patients through our virtual hospital during this time. We had them visited by our community paramedic program, and also reassigned some of our nurses from our home health program to help us meet the needs of our patients at their homes. So I would say the expansion and growth of virtual, it was like on steroids. So being able to really rapidly move that forward and stand it up really helped our capacity issues on the acute care side.
At UCLA, we had similar challenges as well. And we had been very reticent to use any kind of telehealth at all. And it's funny, as soon as people started to think about coming towards the hospital to be ruled out for COVID, the telehealth went off like a rocket, because what we did is we realized we already had capacity issues just in our normal life. Our major goal with any of the things we set up regarding COVID was to keep people away from the hospital campuses, because we wanted to mainstream them to stay home. Most of the people who were complaining of COVID signs and symptoms did not require hospitalization. So the worst thing we could do was start to pull them into the emergency departments and urgent care centers unnecessarily. Another big learning for us, we had always had a surge plan. So we always knew in the event of a natural or internal disaster, there were several steps we would take. We refined that using some predictive analytics and some other new data. And in the fall, we never got to use it. We never got hit with that first wave the way the East Coast did. And so we were like, great, we've got this, we'll put it away. Well, we got hit in the spring, like right around Christmas, going into the spring. we were editing that the whole way, because what we had planned for wasn't exactly like how it rolled out. So I guess my one takeaway is, as good as the surge plan can be, you have to be prepped and ready to pivot. And the last year and a half has been a very interesting time as far as learning about our flexibility and our nimbleness as an organization. And I'm sure you're all in the same boat.
Mackenzie, I would also say that just building on what Karen is saying, luck was on our side in some ways down south as well. New Orleans was a hot spot. COVID came immediately after Mardi Gras, where we had, hundreds of thousands of people shoulder to shoulder in the streets right before the pandemic. And one of our campuses, the one that you see actually behind me today, had, we were in the process of building a new tower. And, I think your point, Karen, about pivoting was just how quickly the people that you might not expect to help you improve capacity, our facilities people, our supply chain people, our ability to get equipment, we built out and actually opened 100 new beds during the height of the pandemic, because we had space that was fairly well built out and ready to go, and we were able to get the equipment that we needed to open those rooms. And so when I say it was all hands on deck to create the capacity that we needed to manage the volume of patients that we had at any one time was 1,000 COVID positive patients. Everybody played a role in that. And I think the other big takeaway that we had was, how do we train people when we need to pivot? And so just like we're having this session on Zoom, we began to do a lot of our training for frontline staff and had 24/7 virtual support for people who were not used to being at the bedside. And frankly, that changed the way that we even onboard people today, now that we're past the height of the pandemic, and we're using a lot more virtual education for staff and a lot more virtual onboarding for staff.
That's really interesting. I think, that point about pivoting and even knowing when to pivot is so crucial, especially during something as unprecedented as a pandemic, when it can be so hard to predict what sort of capacity management you're going to need, or what a surge is going to look like for something we haven't seen before.
And I think for some of us, Tracy, more than likely being down in Louisiana, a lot of us have been in places where natural disasters naturally occur. Hurricanes come to mind. Similar to a hurricane or a really bad nor'easter, a lot of us have had experience prepping and being ready to receive the storm. We were dealing with a lot of new kids. We were dealing with a lot of people who hadn't seen anything where we were. The closest disaster we'd had was 1996, which was the big earthquake in Northridge. Other than that, there had been, knock on wood, very few disasters of any kind of proportion that would have created this level of intensity. That's a long time. So there were a lot of people who were just wowed, a lot of shock and awe, right?
Absolutely. And I think it does speak to the power of, like you mentioned, Karen, analytics and new tools to help you predict that or try to get some sense of what might be coming. I'd also like to talk more about nursing workforce management and how your organization's approach to that has changed during the pandemic. Maureen, do you want to kick us off there?
Sure, thank you. So from a nursing workforce perspective, I think it was mentioned, Tracy had mentioned, and even Karen, I mean, with the shutdown of the ambulatory world, what became quite clear to us is all of the acute care world were on the same scheduling system. So we could easily see where our resources, our valuable resources were, but the ambulatory world was not on the same platform. So that really became a challenge, and we had to quickly get them on the platform so that we could reassign to help us with the pandemic from that perspective. So I think hindsight going back, it's something as we're looking at really moving valuable resources in our teams across several different care areas. It's so important that we have sight to that, and we have it through having everyone on the same platform with regard to scheduling and staffing. So that was critically important. And I think that Tracy had mentioned too about the cross training. We could see that this was coming early on, and we did have the benefit of time, unlike the Northeast had. So we made sure that we cross-trained all of our ambulatory nursing staff to be able to be part of a team approach to nursing on the acute care side, which worked extremely well.
We did a lot of hands-on, and then of course with our COVID units, we did a lot with safety officers or safety champions, and those safety champions not only helped with a lot of the PPE management and things like that, they also picked up a staff wellness component and did a lot of debriefing and support of the staff, which really helped us bring people into especially the COVID areas in the hospital, because those were going to be difficult to plan for. We, like Maureen, we brought our ambulatory staff in and had the luxury of, taking our entire education department and putting them to work as elbow support for those ambulatory staff that we needed to orient. And then of course the med surg staff and PACU, because our surgery schedules had been torn down, we took all of our PACU staff and they became the secondary staff for the ICU. Again, very fortunate. We had to use very few of those support staff in the course of our activities here, but we did have our entire complement of PACU staff ready for that first wave that we had. The second wave, we didn't close the ORs. We kept going, but it's really amazing to see the resilience and the commitment that the staff really had to making sure we were successful with the care of the patients in our community. So
yeah. I would just add to that, Karen, I think the other thing that we did not anticipate from our teammate health wellness perspective was the amount of resources that we needed for our own teammates, especially with quarantining our teammates and following them, the anxiety that they were all going through and managing that. I will say that I'm very proud of Atrium Health. We paid every teammate for any time that they needed to be quarantined. They did not have to use their own PTO. For areas outside of the acute care world where in the ambulatory things were shut down, those teammates also received their pay. So I think the support that we gave to our teammates was incredibly important during the pandemic.
Yeah, one of the things that was great here was as this first started and we got into it a little bit, the chancellor essentially and the president of the UC system said there will be no layoffs. And the second thing they did was we were able to give everybody 128 hours of COVID respite time that could be used in the event they were exposed to COVID and needed some kind of support, whether it was family or themselves related, so that they had access to that time. And that time is timing out next week. So, you know, we've been able to extend it to let people use it. Childcare, I think, has been probably one of the biggest things we've had to deal with to support our teams here. That was probably the most devastating, with school closures and things like that.
Yeah, I think like my colleagues, we, you know, we had compensation for employees that were on leave or suspected symptoms even. We had great support from IS, for example. We set up very quickly a lot of dashboards that told us how many employees we had that were symptomatic, how many were in testing, how many were pending their lab results, how many were positive at any given time. And that helped us, to your original question, Mackenzie, with staffing. Like Maureen, we were already on a few years prior to this, we had set up a very standardized 4-week scheduling. All of our campuses are on the same scheduling cycle, same timeline for building schedules and turning them in. And frankly, our HR staff really leaned in and helped us identify all of the resources that we had in the non-inpatient areas, from endoscopy and PACU and our clinics. So our unit directors could look at any holes in their schedules or what support staff they needed, and they could pull from that list, and we would assign them to a schedule. Once they were assigned, we put them into a scheduling process just like we would a regular staff member. So they knew they were going to be assigned to that unit for weeks. And that gave people a lot of comfort, I think, about being displaced or misplaced. And having this ERN program that we set up, we literally had our system nursing professional development team and our clinical educators on our campuses were manning Zoom 24/7, and they would take chat questions from nurses who had been redeployed that might have a question about a policy or a procedure, or how do I reach this doctor? And they were just sort of at the ready to answer those questions. And that was a great sense of comfort for our staff. And then, as Karen and Maureen have said, there were meals and childcare and leave and all those things that helped us keep staff available to work.
And we had a tremendous amount of donor support too. That was great. Everybody wanted to do something to help. We also, I think that's one of the takeaways too for everybody. Really, your HR department can be a wealth of information when you need details about people beyond your reporting structure. We were able to request emergent staff up front. We were able to lay in some other bonus plans and things like that too, but eventually money doesn't buy you what you need. So it's a question of how do you shore that up. So we went to new grads, and we also took all of the people who were on modified duty that could not go to the bedside because of the virus, and they went into call center roles. Some of them went into testing roles, and others eventually went into the vaccine administration roles. So we were able to keep 30 to 50 people or positions open and employed with all of those different new staff requirements that grew out of COVID.
And thinking about all of your nurse staffing strategies today, do you expect to make any changes to this process in the near future, and why or why not? Tracy, can we start with you on this one?
Yeah, one of the things that we're really focused on right now, Mackenzie, I think like a lot of my CNO colleagues, we are struggling mightily right now with staffing. And part of that is related to things like early retirement and burnout and those kinds of things. But one of the things that we focused on most recently is flexible staffing and really maneuvering our schedules to provide people who maybe want to work fewer hours, that, you know, if we can keep them in the profession, but give them a more flexible schedule, that's been really helpful for us. And so maybe a nurse wants to work 2 6s and 2 12s instead of 3 12s in a row. And our unit directors, I have to say, across our whole system have done a great job kind of creating some of those flexible positions. Even before COVID, we had an issue with midday surges on a unit. You know, that's when your churn happens, when, you know, patients are being admitted and patients are being discharged. And there's this 8-hour period where, you know, it feels like madness sometimes. And we've been offering some mid-shift types of programs for staff. And that's been probably the biggest change, is just really flexing people to the extent that we can and to the extent that they want to do that.
Yeah, I would say in addition to what Tracy said, Mackenzie, we pre-COVID needed to focus on our nurse leaders, right? Because they're so critically important, and making sure that they have well-being and resilience. And so what we did was cut their work week to a 4-day work week, which made, you know, was really good for them. But in addition to that, with all of the virtual work that came out of the pandemic, one of the things that we're starting to pilot is a virtual nurse. And so especially in areas where we don't have enough nurses, it's a way to keep our talented nurses who are thinking of retiring, you know, giving them something where we can really continue to use the incredible clinical knowledge that they have. And so we're piloting that now on a couple of units, but as an extra eyes and critical thinking and oversight for our patients. So I'm really excited about where that may lead.
I like that idea, Maureen. That's, you know, you see little bits and pieces about virtual this and that. And I think that skill set would be great, especially with some of our newer employees for that level of supervision. We also were a little remiss in our technology that our staff could have access to, apps and things like that, where they could go in and fill in a shift without having to come in or call into the unit. So we had constructed some makeshift ways to do that through the float pool during COVID. But what we've been able to do is upgrade our staffing and scheduling system now. So the staff have all of that on an app. And if they want to sign up for a 6-hour break shift or pull an extra shift, there's a mechanism now for them to go in and just sign up for it. And then of course we have approval processes and things, but it's ease of use for them if they want to pick time up.
Yeah, similarly to Maureen's point, we had launched a virtual nurse bunker at one of our campuses about 1.5 years ago. And through that, we were able to stretch our med-surg staffing assignments a little bit. And our bunker nurses, if you will, forgive the phrase, but they know they're in a bunker. It's like EICU, but it's e-med-surg. And they take a patient assignment of 20 patients. And frankly, they were a godsend to us at our Kenner campus, where we had two big ICUs running. And, you know, they would catch things, lab results and radiology results and gases and those kinds of things that our frontline staff were just sometimes so swamped they might have missed. And so it was a huge safety investment for us. And we knew that going into COVID, that it was going to produce great results for us and employee satisfaction. But during the pandemic, it was really a very important solution for that particular campus.
Just going to add on to what Karen said, you know, it's great to see so many organizations take advantage of new technologies, utilize apps, get creative in that. And what you can do with that information is absolutely actually astonishing, how you can have it flow into your other tools. So then you can easily recognize when you have more team members to run more operating rooms, when can you open up additional floors or open up additional beds to staff. And so it's been exciting from my perspective to see hospitals take that leap, you know, in advancing their capabilities technology wise, and then integrating those things together. That's really bringing interoperability together to do that and to match all of the supply and demand that you have in your organization. So.
Absolutely. And Ashley, let us stick with you for this next question, actually. I would be remiss if we talked about all these changes without acknowledging change management as well. So from your perspective, what are some best practices to get not just nurses on board with a new effort, but also maybe surgeons, anesthesiologists, anyone else who is involved in those clinical workflows?
Yeah, great question. And, my approach has always been, having been someone in hospital operations for a long time now, working with technology on the other side of the table, you have to bring it all together, right? You can't just offer technology over a wall and expect it to be utilized to its fullest. You really have to marry the people, the process with the technology to see advancements. And that's capable today. We're seeing that in a lot of healthcare organizations. Healthcare organizations are realizing we might want to practice with best in class or best of industry for various efforts, whether it be a technology related effort or advanced analytics. While you can do a lot of things internally, behind the wall of the health system, that might not always be the best practice, or you might not learn the latest or the greatest that technology or other resources have to offer. And so I'm seeing more partnerships, and I think that's great. Having been someone that spent a tremendous amount of time and effort building dashboards and reports for leaders like those on this panel with me that they can use every day, that's not always scalable or fully reliable. It requires a lot of auditing and maintenance. So I really do think it's important to not only marry what technology has to offer today to our healthcare organizations, but then to do so along with the process you have in place and the people to enhance it all. And honestly, everyone's work can be improved, their work-life balance can be improved, and at the end of the day, we can be more efficient in our hospitals.
Yeah, I think one thing I'm getting from our discussion is it really is all interlocking and interrelated so much between nurse scheduling, patient care, staff well-being, along with how you marry those people and the processes. I'm curious, maybe Karen, can you start us off? How do you see that relationship between nurse staffing and staff well-being, which is so crucial right now, along with the patient care aspect?
I think what we've been trying to do now is figure out how to get people time off. Tracy alluded to it earlier. People are tired. You can see it in their interactions with people. Sometimes they're a little sharp or a little short, increased sick call, some other things like that. So what we've been trying to do is how do we fix that? And, leaders we've identified with the staffing office, what we've done is we've started to backfill some of our medical leaves and leave of absences with permanent folks from the float pool for the entire anticipated length of stay, instead of them getting a random person every day, so that they can put together some relationships and get some continuity going. The float pool's been great like that. And then they've re-upped the number of shifts covered per day based on what we've been trending. So, it's not unusual for us to have 20 med-surg nurses in the float pool, plus whatever we've loaned out to help cover what's going on day to day across for this purposes of the 2 acute care hospitals. And there are still days now that we're struggling, it's not enough. Some of the well-being things we've been able to do while we're just making sure we've got everybody covered. I host a 1-hour open forum every 2 weeks for all comers. And we actually had staff and faculty services start to offer a resiliency and kind of a self-reflection hour every couple of weeks for the past 3 months to help people kind of get back to basics about themselves, so that when we did encourage time off, they would take it. We still have people who haven't quite gotten used to the fact that we're opening up again. So, for California, we were quick to close and slow to open. And we still have a lot of people, even though the governor has written that order, we still have a lot of people who are hesitant, including a lot of healthcare employees. So we're really having to be very ingenious in the staffing office with best ways to help cover, because we're in uncharted water right now. We don't know what to predict, to project, 2 months from now. So we continue to watch and wait. We have, this past year, we also built in a career float pool made up of full-time staff that are always here, and then peppered the per diems around it. So that is a change we've made to give us more of a core availability day to day, month to month.
And I was going to add to what Karen said. I mean, I don't think we fully know the extent of the impact yet of the pandemic on our workforce and nurses and other clinicians. What we have at Atrium is Code Lavender. Code Lavender came from the Cleveland Clinic, and we set it up here in 2013. And our compassion champions were critical for going out, meeting our teammates and physicians out on the units and offering the resilience, the conversation, the importance of self-care, and just giving them permission to vent, right? To just let it out. The other thing that we're looking at is trauma-informed care. We think that's going to be an option that we're going to be looking at driving across our enterprise. And that really it's an organizational structured approach for both patients and staff that really helps them understand the impact that trauma has had on their well-being and gives them a better understanding and tools to help them deal with that. So I think that's going to be important too, as we continue to recover from the pandemic that we've all been through.
Mackenzie, I'll say one more thing about just sort of support for the staff. What really inspired me as a nurse, leadership aside, was how the areas that were not as deeply affected by COVID came to respond to our staff that were. And so our mother baby staff, our pediatric staff, even our EDs slowed down quite a bit because everybody was afraid to come to the hospital unless they absolutely had to, right? And so all of those nurses were sort of out doing everything they could, delivering meals and providing empathy and compassion to the staff that were on the front lines and offering to do what they could so that somebody could have a bathroom break or go to one of our quiet rooms for a few minutes. And so I was really inspired by the profession generally about how supportive they were of each other and how much they leaned in to make sure that the nurses that were truly being affected by COVID were getting the support that they needed. And they were the ones that would come to me or call our campus CNOs and say, here's what we need at this campus, or here's what we need at this other campus. And that was really inspiring to witness also as a profession, how well our teams came together.
Yeah, I totally agree, Tracy. That was amazing that people just opened themselves up, and what we normally deal with on a day-to-day basis was put aside, right? But the other thing that I think was so important was allowing our staff, especially on the acute care side in our ICUs, the ability to go and staff our vaccination units. For them, the feedback that they got from patients in our community when they were getting their vaccine, they said they felt like they were getting a shot of hope. And so I think that for our teammates that went through such tragedy on the acute care side, to be able to give that injection of hope was huge, I think, for many of our staff.
Yeah, our staff, similar to Tracy and Maureen, but the other piece we got was a lot of innovation. We had a lot of staff chatting up how to do things easier, better, or differently, both in interprofessional teams or just, 3 nurses having a confab somewhere. And we really found a lot of first-rate solutions that will stay with us for a very long time because of their ingenuity and their dedication to each other and their patients. We had the nurses in the other ICUs, they did big wall murals for the nurses in the COVID units, and they brought them food and all those kinds of things that nothing anybody had to do. But to have a group of nurses from one ICU say, I want to come down and volunteer to work in your unit to help you. There wasn't another thing any one of us could have said to those people that would have reassured them or made people feel as comfortable as they did. So we have a wonderful group of people in our profession, and they really did shine.
Absolutely. I think that immense collaboration and support was one of the few silver linings of such an unprecedented, horrible time in many ways. And Ashley, I want to tap you for this next question too, because I know you did previously practice as a nurse before joining LeanTAS to work with health systems on capacity optimization. So I think you have an interesting dual perspective here. What would you say are some learnings that you feel nurse executives at health systems should apply in their decision-making process when it comes to capacity management? I know Maureen said sort of the next few months could be unknown, and it's a difficult thing to navigate.
Yeah, for sure. Thanks, Mackenzie. And while I'm not a nurse, I have been honored to be trained by nurses my entire professional career and have learned so much from them, both on hospital management, leadership, and I spent a lot of time in surgical services. So I guess my thoughts on that topic are, the need, and honestly, leaders need to demand access to credible, reliable data, almost real time. We can't empower you to do your jobs even better than you already do without giving you that reliable information. Certainly gut and intuition go a long way. And we've had many, many decades where we've done everything on the back of an envelope with a pencil and, a phone in our hands. But there are new advancements today. And as hospital executives, I hope that you all either have them or are working towards bringing them into your organizations, because what I see hospitals do with access to the right, reliable, credible, timely data is fascinating. Gone are the days of having to pick up the phone and call every unit before the huddle in the morning. Gone are the days of having to have everyone physically present in order to have an effective huddle. Today, now we see healthcare leaders and we work with them all the time, and we help them to know, when can you anticipate needing to open surge? Certainly the pandemic brought a tremendous amount of spotlight and need and focus around those activities of surge units, closing surgical rooms, postponing, all kinds of procedures. But that was happening before too, for other reasons. Staffing shortages, anesthesia shortages, whatever, resource shortages, you name it. But now really we can help hospital leaders anticipate and reliably predict that much further in advance. So what's going to happen? Well, you're going to better serve your patients at the end of the day. You're going to better meet the needs of your providers. And as we're talking today, the needs of your nursing staff, to not have to scramble, call everyone, beg people to stay late, but to predict those needs further in advance. So you can shift, you can pivot, you can I'm seeing it every day. Today, in fact, I was just on a phone call earlier today with a healthcare organization in the country where, we're really helping them shift a lot of their surgical volume to a new location and utilizing staff for that as well. So then they can prioritize other things at another location. So it's being innovative and marrying that technology with that process, and that having that appetite for change is what's really helping organizations like those on the call with us today and others accelerate their progress in efficiency management.
Absolutely, it's true. It really is just such an exciting time right now to not only improve hospital operations, but then obviously that's going to have a trickle-down effect on nurse well-being, patient care, and everything. So I appreciate you all so much for taking the time to speak with us today. It's been such a pleasure to hear your thoughts. But I'd also like to thank our attendees for taking some time out of your days to be part of the Beckers and LeanTAS Hospital Operations Virtual Summit. As a reminder, please feel free to check out our additional resources and fill out our session survey, both of which can be found on your attendee dashboard. Thank you all again so much for joining us, and we hope you enjoy the rest of the event.